a very small amount of reconnection gives a very large amount of benefit. The injury we're going for is an injury where nerve fibers are pulled out of the spinal cord. This is the normal situation where nerve fibers run into the cord. If they're damaged, they regenerate as far as the spinal cord, turn around and stop. And the effect is that the arm on that side is completely paralyzed, useless, and without sensation, but extremely painful at the same time. If we transplant olfactory and sheathing cells into that, the nerve fibers grow back into the spinal cord. And here's where they do it. This is the normal nerve entry point. This is the nerve removed. We stick it back, nothing happens. We stick it back with olfactory and sheathing cells, and you can see this ladder-like structure through which the nerve fibers, they're here in red, are running. These are the transplanted cells in green. You can see them running together. So the ladder-like structure linking the nerve repair with the spinal cord, and there are the fibers going through. This is the human operation, which is a routine surgical operation. This is human being carried out at Queen Square, and this is a nerve graft being pushed through the dura from outside into the vertebral canal by Professor Thomas Karlstedt and David Choi, who are working with us. These are the nerve grafts coming in here. The denticulate ligament is pulled back. We do all this in the rat. This is the human version. Here are the grafts. These fibers will be trimmed, and then they're pushed back into the spinal cord. This is not an operation without risk. There are risks attached to this operation. It has to be a decision whether to go for it. Now, from spinal roots, if that is both safe and effective, and those are two ifs, we haven't done it yet, starting next year we hope, that will open the door to a much larger field: spinal cord, stroke, deafness due to nerve injury, blindness due to nerve injury. All these are going to require further technical modifications, but this will prove that the cells are effective and safe in reconnecting, and then we can start to go through that door. We have to open the door with this.
First of all, we can eliminate a maximum number of cancer cells by high-dose chemotherapy and support the patient with autologous stem cells. But then we need a step 2, immunotherapy of minimal residual disease. And we do immunotherapy, I'm sorry, some of the quality is because it transformed from Macintosh. We think that the most effective approach to kill the last tumor cell is to obtain allogeneic foreign lymphocytes. This is just an example of one of the first patients we treated using this strategy. First, be strong, as much chemo as you can, and then be smart to eliminate the few that escape chemotherapy. You can see this woman, a Filipino girl, had leukemia, could not be cured in Manila. She was sent to UCLA, to Los Angeles. They couldn't put her in remission, and somebody suggested to come to Jerusalem. You can see we did high-dose chemotherapy supported by autologous stem cells, but already 1 month later she has positive leukemia cells in the blood and in the bone marrow. So it was obvious she was not cured, but she had a stage of minimal disease. So we used mother cells, which are fully mismatched, and for the first time she turned negative, but only for a short time. And then we used killer cells generated from the mother, amplified in the laboratories, I'll show you later, and you can see that she became completely negative. This was in 1992. Here she finished the college in year 2001, came last year as a tourist to Israel. Now she's third year's graduate medical student, and this year, if I could show you the picture, she is getting married.
So we got a variety of cells that can be used for regenerative medicine, and to my mind, I'm not aware that anybody has attempted, and that would have been a mega task, to compare systematically on the same system which cells source will be best to repair a particular diseased tissue. And it's likely that, like in medicine, it will be a question of accommodating to the needs of the patients, and it may be either combination or selection of certain cells for a particular task.
I'm now going to pass briefly to talk about our new program, which is due to start at the beginning of next year. There was an agreement of the Council of Ministers at the end of July. So the path is now clear for continuing with the approvals process and hopefully launching the first calls for proposals either at the very end of this year or at the beginning of next. The program will consist of 4 main areas. The green is our in-house research. It doesn't really concern us now. The top one, called cooperation or collaborative research, is really what I've been talking about. That will continue. That will continue to be the major part of the program, the bread and butter of the program, if you like. There is a new departure here, what we call Ideas Frontier Research. This involves setting up what we call the European Research Council. It's already in place, and its objective is to support basic science.